An educational grant for HealthWise is provided by Alcon Surgical.
Welcome to HealthWise on WTVI. I'm your host, Joey Popp. Now, it may sound too simple, but the reason for regular medical checkups is to stay healthy, right? Well, what happens when we find there's a condition we need to address because of that checkup? We do something about it. Isn't that right? Well, today's topic falls into that area of, well, I didn't know I had a problem until I went to the doctor. We're talking about cataracts, and this broadcast is dedicated to what's new in cataract surgery. Returning to HealthWise are Doctors Kashyap Kansupada and Donald Stewart, ophthalmologists with Charlotte Eye, Ear, Nose, and Throat Associates. Is it a shock to your patients when they're told you got a cataract?
Many times it is, because when they come in for the first time in their probably late 50s, early 60s, they notice that their vision has changed a little bit. They think that their prescription has changed, and suddenly they find out, oh, it's actually a cataract that caused the change in the prescription, and sometimes they're very floored.
But they don't realize that they've had a change in vision where perhaps there is a cataract, Dr. Stewart?
Well, sometimes people think that just their glasses need changing, and in fact, a cataract is often a very common commonly causes a change in eyeglasses. So oftentimes we're able to tell the patients we can correct your vision by changing your glasses a bit due to an early cataract formation, or sometimes we have to tell them that the vision cannot be corrected adequately with a change in glasses and that cataract surgery may be necessary.
Exactly what is a cataract? Let's start with you, Dr. Kansupada.
Cataract is basically a clouding of the lens inside the eye. It sits right behind the pupil. And it usually happens over time. It can start as early as in your 30s as far as early clouding, but it doesn't become really significant until your 50s and 60s. But basically all it is that the natural lens, which is crystal clear, becomes cloudy.
We have quite a few visuals tonight. Hey, that's appropriate, isn't it? We're talking about the eyes.
That's right.
So let's go to our first visual, and this is actually the anatomy of the eye, so this will give you a definite picture, if you will, of what we're talking about and where the lens actually sits. Dr. Stewart?
This is a schematic of the eye, and this is a detail of the front of the eye. Number one is the cornea. Light passes through the cornea and then passes through the pupil, which is part of the hole in the iris, which is number two, and then finally passing through the lens, which is labeled number 3 and 4, before it heads back to the back of the eye, which is the retina. And number 3 and 4 is the human lens, which becomes cloudy in a cataract.
So that lens actually sits right behind what we normally see when we look at someone's eye.
Exactly.
Can you look with your bare eye and tell if somebody has a cataract?
Well, it depends on how bad it is. An early cataract probably is not visible to the casual observer. However, a very dense white cataract is typically observable to someone else looking at you.
We have a piece of video that we'd like to show you now. This is animation, and this is how light goes into the eye, and if you will, the eye will resemble a camera, and Dr. Kansupada is going to explain exactly what this actually shows and what it wants to tell you. Let's roll that video. How the eye works.
What you see here is how the eye is very much like a camera. A camera has a lens which focuses light on the film. Similarly, the eye has a lens, as you see here, and it focuses the light on the retina, which is kind of like the film of the eye.
So what that actually goes to is the back of the eye. Now, we're going to go ahead and go right into, continue rolling that, if you will, Frank. We were going to do a pause, but let's go right to it now. This is the clear lens versus the cataract lens, and for someone who has a cataract, this is what they see. That prism actually doesn't hit the back of the retina, right, Dr. Stewart?
That's correct. This is the lens showing a nice focus on the retina. That's a clear lens, so light coming through is nicely focused right on the back of the eye. And this is showing a cataract lens. You can see the dark lens there. Light comes through, and rather than being focused to a pinpoint, it's broadly diffused, giving the patient a blurred image.
All right, so exactly how does that lens become dark that we saw in the animation? What causes a cataract?
Great question. Cataracts are something that can form at any age, But cataracts typically form as a result of proteins depositing in the lens. And drugs can cause that. I mean, prednisone, various medicines that people are on. Smoking may increase that risk. But sunlight and age are probably the two largest factors.
Is it true that perhaps we don't know why people also get cataracts?
That is true. Many people develop cataracts for no apparent cause. And people, Dr. Kansupada and myself will typically operate on people each week who are in their 50s, 60s, and 70s, but occasionally we will operate on someone who is in their 30s, 40s, and 50s. And sometimes younger. Actually, babies can be born with cataracts. So anything that causes a clouding of that human lens, whether it be trauma, which can cause it, or just natural aging, and produces an opacity within that lens which prevents light from passing through it clearly, is a problem for the patient. And that's where we come in and may be able to help that patient out by removing that opacified lens and putting a clear one in its place.
Key word, a problem, you said, perhaps for the patient. But is it a concern? Is it a health hazard if that person doesn't do something about the cataract?
We get that question all the time. Will it hurt if we just wait? And no, it would not hurt to wait. But occasionally when it gets to the beyond ripe, so to speak, when the lens swells up to a great degree, it crowds the front of the eye, and this blocks the drainage ports that we have, which drains fluid. And suddenly the pressure can go up, but that's a rare complication, but certainly something for a majority of the patients should not even enter in their decision process. But yes, there is a very rare chance you could have that problem when the cataract is let go for a while. But for the most part, we encourage folks, if they're not having any difficulty performing their daily activities such as reading, watching TV, driving, enjoying church services, and we recommend they just watch and wait.
So it's a quality of life issue we're talking
Absolutely.
about.
Absolutely.
Yeah.
And of course, as with any surgery, there's always risk involved. There's a chance, a small chance, that the surgery might produce some problem for them, you know, for instance, infection or bleeding or retinal detachment. Mm-hmm. But the risk of that type of problem occurring is probably 1% or less. So the patient has to weigh the likelihood of a problem occurring versus the expected reward. And for most people, cataract surgery is highly successful. Mm-hmm. But obviously we don't want people to go through that unless they feel that that's a risk that's appropriate for them.
And that's exactly why we are using this topic tonight to explain, and as a public service of our medical panel being on, explaining what the very latest is with cataract surgery. We have another few visuals to go through. We're going to go back in time. BC, we have a actual rendering. This is going to be visual number 3, guys. And this is what's called couching. And this was the practice of removal before Christ, right, Dr. Kansupada?
Absolutely. Back when the time of Sushruta, one of the old ancient Indian surgeons, what they used to do is take a special instrument, basically a sharp instrument, probe, and enter the eye from the side where the colored part meets the white part of the eye, and essentially press the mature lens, which is basically hard as a rock, back. These are folks where the vision was basically, they could only see light, and that's it. And so it was, to push that back and then suddenly see shapes was a big advantage back then. But of course, things have improved since
right. Then. And then we're going to go to the progression of clouding, which is another visual. And this actually shows you how the natural lens can continue to get dark and dark and dark before what? No prism goes to the retina.
Exactly. This is a diagram showing different human lenses at different stages of life. The ages are listed on the right, age 40, 50, 70, and 80. And you can see that with increasing age, the typical person has a darkening of that human lens, almost like a piece of glass becoming stained, and it becomes harder and harder to see through it. And you can imagine that that lens down at the bottom, where number 80 is pointing to, would be very difficult to see through, and images would be very blurred, and the patient would have a lot of difficulty reading the newspaper, driving, seeing the things that they need to see. So that just gives you a nice example of how that human lens progresses over time.
And the other image that you see right next to the darkest one is sometimes they can turn white when they become mature. So it's interesting how they go through this initial brown discoloration, but then when it gets really mature, it can actually turn white.
And even though it's white, that patient cannot see through the lens, correct?
Absolutely.
Exactly.
It's as if they are looking through darkness.
Exactly.
Yep.
Wow. Okay, now there's different types of cataracts, I've been told.
Correct.
And I think you brought us some slides to explain what they are. And why is it important to know? I mean, if I go to a doctor and they tell me I have a cataract, why should I know what the difference in cataracts there are?
Well, primarily because of the type of symptoms they create. For example, the nuclear cataract, which we'll see in a few minutes, causes a shift in your prescription initially, and you need to turn on the light a little brighter in order to see things to read. It helps you understand what's going on with yourself. And now the other kinds, like the cortical and the subcapsular cataract, cause more glare symptoms. So if you're told that you have that type of cataract, you could be a little more aware of when you're driving at night, is the glare really bothering me that much or not really? So in that way, I find it helpful to explain to patients what kind they have.
Sure, but there are these things that we need to be aware of, but also it's just a classification system that the eye doctors employ that help us to keep records of how people advance from one visit to the next. So it is helpful if a patient knows that they have a type of cataract that may produce a certain kind of symptom. We'll go over those in just a moment and show people what those are like. But in the end, they all leave people with various states of difficulty doing the things that they need to do with their eyes every day, like reading the paper, seeing street signs as they drive.
Quality of life, like we were talking.
Absolutely.
Now, is there a difference in a cataract in a 30-year-old as opposed to an 80-year-old? Or is it the same type of cataract?
It can be different in the sense that the cataract causes the same kind of problems in their lives, but when we take out the cataract is typically very soft and almost like a gummy bear type of consistency when you're 30. But when we're in our 60s and 70s, it's a lot more like a rock or hard candy type of thing.
Okay, well, let's go to some of these visuals. We're going to go to the nuclear cataract, which is our visual number 6. And what are we looking at here?
This is a nuclear cataract, and you can see that the arrow on the upper left is pointing to the cloudy lens, and on the upper right, this is a depiction of what the patient might see. This soccer player's image is blurred, and on the bottom left is the view that the ophthalmologist gets with that special instrument we have in the office called a slit lamp, and it shows kind of a cross-sectional view of that yellower lens, indicating that there's moderate cataract there. Then on the lower right is an image at night as a patient's driving, and you can see that the lights are all sort of larger and kind of have a halo around them, so things do not look distinct. And that's because that light coming through the human lens is not being properly focused in a nice pinpoint fashion as it normally would. So that's a nuclear cataract.
Let's go to the cortical if we can, which is our next visual.
Cortical cataract is clouding of the more peripheral parts of the lens, and so during nighttime driving, when the pupil is dilated, as you see in this image on the left-hand side, it exposes the flex, and when light hits it, it gets diffracted in different ways, causing glare, like you see in the upper right image from a street light, and in the lower right image from a normal person would see on the right-hand side just regular headlights, but someone with cataract would get on the left-hand side a lot of glare from that and making it challenging for them to drive comfortably.
We're talking about a safety issue here also, aren't we?
Absolutely. There's been studies that have shown that folks who have cataracts are prone or at higher risk of developing or having more motor vehicle accidents, as well as falls and hip injuries.
Let's go to the next visual, which is going to be the starburst, and this is really a case of double vision. Starburst cataract.
The cataract is depicted on the left. You can see that sort of white cataract with the arrow pointing toward it. And then on the right is the view that the patient would get looking at a building, and you can see that the central area is all fogged out there.
Is that double vision?
Well,
no, it is not.
No, I think that may be in the next slide.
Let's go to the next one then, if we can.
This slide shows on the upper photograph, there's an arrow on the right pointing to the cataract in the eye, and then down below it shows examples of starbursting and double vision.
I misspoke. The one before, and let's go back if we can, that's the posterior subcapsular. Yeah, explain that one. Now that we've seen the starburst and the double vision, explain what this one is.
Okay.
And what it's called.
The posterior subcapsular cataract is, rather than the whole lens being diffusely yellow, it's almost like someone took a piece of glass and painted some white opaque coating on the back. And typically this will often give people a central blur because they tend to start off centrally.
Wow. Now, you know, we have addressed macular degeneration on this show several times, and that looks like central vision being affected, like macular degeneration.
Absolutely, except this is a much better thing to have because obviously this is fixable very easily, whereas the macular degeneration presents more of a problem.
Understood. Okay, and then let's go to slide number 10, our visual number 10 if we can. And this is the A scan, which is the pre-op visit. And explain to us what the technician is doing here to the patient.
Yes, the patient's reclined, as you see, and the technician has a probe in her hand. And the probe is used to, once the eye is anesthetized, numbed, is used to measure the actual length of the eye. Based on that length, we can then calculate the exact lens implant size or power that we need to use to implant. It's kind of like shoes. They come in different sizes, and so we need to find out which lens we need to use.
Well, we kept saying at the top of the show that we're going to be talking about what's new in cataract surgery. We are now going to show you a series of animation clips. And these are very exciting to watch, and this is some of the new technology that we've been talking about. So we'll let the doctors do a little play-by-play as we roll the video. Let's go ahead and go to it. Dr. Stewart?
This is going to show typical removal of the lens. The tool on the right is called the Phacoemulsification handpiece, which I'll show you in a moment. And this shows dividing the human lens into pieces and removing them quadrant by quadrant. And now the lens is gone. And at this point, the lens would be placed in the eye. This is the artificial lens, which replaces the human lens. And this is a picture of the device that has these two flexible arms called haptics, which help to hold it in place so that no sutures are required. And it's actually injected through a very small incision, at which point the lens unfolds in the eye. It's really neat stuff. And it allows everything to be done through a 2.5 millimeter incision, which is just incredible.
Wow.
This is showing that light goes through that new lens nicely and comes to a pinpoint. This is another technology.
If we can let that video roll, Frank, thank you.
Called AquaLase. This is a neat technology that's brand new. It uses a water jet to remove the human lens. And this can be used in many of our cataract patients to more safely remove that cataract. So this is brand new technology that is available here in Charlotte today. So it's called AquaLase, or water jet removal of the human lens, and it allows the lens to be removed more safely because not as much heat builds up as you get with the ultrasound.
So if it wasn't for that actual procedure, how would you take out the lens once it's been defragmented?
If it weren't for which procedure? I'm sorry.
Oh, as far as taking out the natural lens.
Oh, if we didn't have the
AquaLase.
AquaLase. Well, the previous technology, which Dr. Stewart had showed, was with what's called phacoemulsification, and that's a $10 word for emulsifying the lens using a high-frequency ultrasound machine. And it goes through, again, a very small incision, about 2.5 millimeters in width. And yeah, here's actually what the handpiece looks like. And what you do is you hold it like so, and at the tip there's actually another piece that goes right here, which allows us to remove the...
Dr. Kansupada, if you would please just hold that perfectly still, and we're going to have Richard here zoom in on this with his powerful lens. Now, explain to us what we're looking at.
Yeah, this is what's called the phacoemulsification handpiece, and there's a little wire here that provides electricity to this machine, and in front of this is a little tip here that we use to actually remove the lens implant right here. And the entire process takes about 7 minutes.
Okay, so with the AquaLase, that is even more advanced, and is it safer than the other technology?
It may be, Joey, because the AquaLase uses a handpiece that looks very similar to this. And the advantage is, rather than using ultrasound, which can generate some heat, then that's how these are currently done. And actually not much heat, so it's still a very safe procedure. But
Right.
AquaLase can be used for some cataracts, not all, but some of the earlier cataracts, early stage cataracts can be removed with AquaLase. And it uses a little water jet, and you can actually hold your hand right over the tip as it comes out, and it will not burn your hand. So it's really, it's a brand new technology that is really is going to afford the patients a bit more safety than was previously available.
This will be especially important as we move forward in the technologies that we have available for patients, where as the patients become younger and younger and we look at newer implants that allow you to see far away and up close, there'll be a lot of patients who, even before cataracts begin to form, will want to have their lens removed potentially and have these new implants put in, so that allows them to see far away and up close simultaneously without glasses. And the AquaLase technology, we feel, might fit the bill on that, where we really provide very little injury to the eye.
All right. Now, you've also brought us, we saw the actual lens being put in the eye with, looks like hinges.
Yes.
And you've brought us a model here on set. So if we could zoom in and look at this right here. Dr. Stewart, it is quite small. It almost looks like a contact lens with legs.
Well, that's exactly what it practically is. It's a little lens, and it has these little arms on it here, which are flexible. They're called haptics, and the whole lens is actually flexible. I'll take this other instrument and bend it over, and you can see that it is bendable and flexible, and that's what allows it to go through a very small incision. This lens is actually slightly yellow, and we'll talk about that a little bit later in the show. But this is the current state-of-the-art intraocular lens, or replacement for the human lens.
And why for the hinges? Is it to give stability once it's placed in the eye?
Yes. These little arms, called haptics, allow it to center itself in the eye. So each arm sort of keeps it centered and allows it to stay in there without stitches or sutures.
Okay. Okay. And then I think you've also brought us the actual instrument that injects that, correct?
Yes, this is the injector, and I think you saw it in the schematic earlier, but the lens goes into this cartridge right here, and then this little screw is turned, and it forces the lens right out the end of the cartridge.
Okay.
And the cartridge basically is about 1.5 millimeters or 2 millimeters wide. So all of this happens through a micro incision, which allows for much faster recovery. You know, I remember when we were in our training, the incisions at that time were 10 millimeters long. Today, incisions are 2.5 millimeters, so there's a big difference. So really no stitches are required, no needles, and patients can go home the same day, and many of them are back to their normal activity within 24 to 48 hours.
And you're a young guy, and so for you to go through training just, what, a few years ago, look at the advancements since then, huh?
It's really fantastic.
Wow. Okay, let's go to visual number 12, and this really does tell what the doctors are talking about here, with it being, in most cases, an outpatient procedure. Here is a patient with Dr. Kansupada. Well, you tell us. You have a big smile on your face.
Well, this is one of my patients that literally about 5 minutes from getting off the operating table is in the post-operative recovery area, and you'll notice several things. One, she's in her street clothes. They don't frequently have to change their clothes anymore because it's a very quick outpatient procedure. Number two, we very infrequently wear or have shields or patches anymore because of the integrity of the wounds that we are able to construct. And as you can see also, if you look carefully, the eyes are pretty much white on both sides. It's really hard to tell which eye we did, but it was indeed the left eye that was, since it's dilated, you can tell that was the one we did.
Wow, that's amazing. Now, we're also here to talk about what's called wave front lens.
Yes.
And how does that differ from these other lenses that we've seen so far? And let's go to the visual if we can. It'll be visual number 13.
The wavefront lens is a dramatic step up as far as its ability to create a very clear image. What we used to is actually taking a lot of the technology that we use for LASIK surgery, the wavefront technology, where essentially the machine or the instrument picks up irregularities in a visual system. And so lens makers have now applied this to lenses. And from the previous lens to this upgrade, the quality and clarity of the image has increased by 50%. And this is especially important in what we call low light type of settings like fog, driving in the rain, dusk, that kind of settings, where that kind of clarity really helps.
Now, that looked yellow to me, and you said that another lens is yellow. What's the purpose of the color?
That's a good question. These lenses, this is a new technology where this yellow tint has been placed in there, and there is some evidence that by blocking blue light, which is what this yellow tint does, it may block the harmful blue rays that may contribute to macular degeneration. So it really points out that with modern cataract surgery, we're also trying to prevent some of the other problems that have occurred in the past. And that was that we didn't used to block ultraviolet light. These do now block ultraviolet light. And now we are able to block blue light, which may contribute to macular degeneration.
It's like having sunscreen in the eye.
That's exactly right.
That's true.
But am I going to see yellow?
No. It's interesting because if we know that when patients have one of these placed in one eye and a non-tinted lens in the other eye, most patients cannot tell a difference.
Wow. We have some callers, so let's go ahead and take a break from our visual show here, and let's take a couple calls. We have Joan from Charlotte. Hi, Joan. Welcome to HealthWise.
Hello?
Hi. Your question tonight.
My question is, if you had the surgery and you have a line that goes through your eye after the surgery, did they put in the wrong lens or something, and can you have that corrected?
Thank you for the question.
If you've had surgery and you have a line that goes through your vision, does that line float? Does it seem to float around?
Just from one side to the other. And like if I put my eye one way, I can see a little above it, and then I can see mostly below it. So
it could be
when
that
I'm looking at you, it's just kind of very weird.
Yeah, it's difficult for me to say without having examined you, but one thing that could be causing a vertical line is a couple of things. One is a vitreous attachment where the jelly inside the eye comes loose, and you're seeing just the edge of what we call the Weiss ring, or piece of the jelly in your line of sight. Another thought is that it could be a wrinkle in the capsule, or the lens sits in the lens implant sits in a capsule, a little bag to hold it in place. And sometimes you can get a little wrinkle in that capsule, creating a linear type of artifact, which is what sounds like may be going on. But of course, I would definitely visit with your ophthalmologist to see what they have to say about that.
Is it correctable?
It may be correctable, especially if it's the wrinkle in the capsule where we take a little laser in the office. It takes about 10 seconds. There's no pain associated with it, and you instantly can regain the vision that you had.
Okay, Joan, it's going to be worth a follow-up visit, I think. Thank you so much for tuning in tonight. Let's go to Rose now. Hi, Rose. Welcome to HealthWise.
Hi, Joey. I was calling to find out. I've had the cataract surgery, and then I had clouding, which they had to use laser surgery to remove. I want to find out, is it possible to have the clouding recur? And if so, how do they handle that?
Okay, good question. Dr. Stewart?
Yeah, Rose has had the laser after the cataract surgery, and typically that will not recur. So once you've had cataract surgery, you had your human lens removed, and then the lens implant placed in the eye. And as the last caller may have had, a clouding can occur over that implant, and that's where the laser is used to make a hole in that little capsule. But that typically will not recur. Are you having blurred vision, or is your vision clear now, Rose?
No, it's clearer now.
Good.
And the other question is, I wanted to commend you, Joey, but also the fact that with the autoimmune diseases, a lot of people don't realize that cataracts can occur so quickly. Mine occurred within possibly a month or two. And I'm fortunate to have a doctor who happens to be on the show, who also specializes in autoimmune-related eye diseases, who, without his help, I don't know where I would have been.
Right. And you sound young, Rose.
I am. I'm 40.
Yeah. So was this a shock at the top of the show? I said, look, if you've been told you have a cataract, it can be a shock.
Absolutely. I had just gotten my glasses, and they had been clear, and I had gone, 2 doctors had checked, actually, and they've been totally clear. But if I use steroids, which I had, and I stopped using in July, and the younger you are, I guess the faster they occur. And, I just can't stress to younger people enough, that if you feel something's wrong, don't wait for 2 years. I know there's doctors that some of the people I have know that say they only need to be checked every 2 years, and I tell them, go to someone else.
Right.
Because they can occur so quickly.
She brings up a good point.
She does.
Because folks with diseases, such as autoimmune diseases like this patient had, lupus, rheumatoid arthritis, all these different autoimmune type processes, but also people with diabetes. That's a very common cause for cataract formation, especially in the younger folks. Atopic dermatitis, psoriasis, a lot of these folks tend to develop cataracts and early in age.
Wow. Hey, Rose, thank you so much for really driving home the message that we've been trying to make from the very moment we went on the air tonight. Half the show's gone. We have another half to go. You're enjoying HealthWise on WTVI.
An educational grant for HealthWise is provided by Alcon Surgical. If you are interested in sponsoring a show, being a guest on HealthWise, or have questions or comments, please contact us at 704-371-8836, on the web at healthwise@WTVI.org, or by mail at HealthWise, care of WTVI, 3242 Commonwealth Avenue, Charlotte, North Carolina, 28205. If you would like support group information about tonight's topic or any HealthWise topic, call SupportWorks at 704-331-9500. For more information about tonight's guests and future HealthWise shows, call the HealthWise info line at 704-371-8836. Learn more about HealthWise and other local productions at WTVI.org. Go to our website and you'll see current and upcoming events on air and in the community. That and much more at WTVI.org.
Welcome back to HealthWise. We're talking about what's new in cataract surgery. Our medical panel this week, Dr. Kashyap Kansupada and Donald Stewart, ophthalmologists with Charlotte Eye, Ear, Nose, and Throat Associates. Fascinating discussion. We've been really trying to get the message, hey, look, cataracts may be a shock no matter what age, and you're here to help us be educated as to what's new with cataract surgery, because if you're told you have a cataract, you really need to have the surgery, right?
Maybe.
Maybe. If it's ripened especially. Let's address that. You're told you have a cataract, you may never need the surgery?
Absolutely. A majority of people in their 60s develop a clouding of the lens. So majority of people out there have cataracts, and they're above ages 65. But it's only when it becomes visually significant, where new glasses or contacts can't allow them to regain their vision that they need to be able to function. And so when they get to a point where what we've talked about earlier, Dr. Stewart and I, they're unable to perform their daily activities, that's when we talk about cataract surgery.
Not only that, but pass a driver's test.
Yeah, that's true.
Absolutely. And that's actually a common hurdle that people fail that causes them to come in seeking cataract surgeries. They fail their driver's license test. Now, sometimes we can just tweak their glasses a little bit and allow their vision to improve enough to get their driver's license, but if not, then they may want to consider surgery.
Okay, so you're told you have a cataract, and if it's not fully ripened, you can hold off surgery, but once it starts affecting the quality of life, by golly, that's when it's time to do something. Is that what the bottom line is?
Absolutely.
Okay. We have bifocal lens implants that we're going to talk about. It's visual number 14. And Dr. Kansupada, I want you to tell us what we're looking at here on the screen.
Sure. What we see are an array of different type of lenses that are available and are going to be available very soon, and these are to address a very common problem that happens as we mature. When we get to the age around 40 or so, the lens inside the eye progressively loses its ability to focus things up close, And so by the age of 60, 70, we have pretty significant bifocals. And right now with current technology, with cataract technology, what we do is we do cataract surgery. They allow them to see at distance, and they sometimes have to have reading glasses over the counter or something like that. Well, these lenses, what they hope to accomplish is to reduce their dependency on glasses completely, from distance and near, to allow distance and near vision simultaneously. And there's two different types that you see here. There's three of them there that you see, the upper left, the one in the upper right, and the lower left have a hinge. And the hinge is designed to allow the implant to shift forward and backward depending on where the patient's viewing things up close. It's quite incredible technology. Wow. The one on the bottom right is a different type of lens, which actually, if you can look very carefully, there's little ridges, little circular ridges that you see there. And that allows light to be focused from different distances on the back of the eye. So, you know, this is up-and-coming technology that very much can revolutionize what we do in cataract surgery.
All of these have been FDA approved?
The only two that have been approved is the upper left, the crystal lens, and the bottom right, the restore lens.
Okay, and I think you even brought us, what, the crystal lens?
Yes.
And if we can get a close-up of this as well. And you're going to tell us why this is so significant, as opposed to the one Dr. Stewart was showing us a little bit earlier.
Can you get that?
Yeah, I think Richard's going to zoom in on it here any second now. There we go.
There we go. I put over my...
Yeah, just hold it perfectly still.
There you go. And what you see here is a lens implant similar to what Dr. Stewart had. And you can see the circular part, which is the part that focuses the light. And you have the little arms on here to help keep it in place. And as you can see here, just by pressing on the top very subtly, you can see the lens implant moving back and forth, just as it would inside the eye. And so this is, you know, incredible technology.
Great. Now, correct me if I'm wrong, but
yes.
I haven't heard good news about this particular lens. Why?
Well, there are, you know, once it's FDA approved, it's initially done with a small group of patients, and then once it's released for general public use, we have more patients with varying conditions using it or having it implanted. And what we found is that the bag in which the lens sits contracts and becomes stiff. And thus, you might lose some of the effect of that lens being shifted forward and backward. So that's a little concern. Well, the other concern is that it is something that's not covered by Medicare and something you have to pay out of pocket. And so that not everybody has access to it.
The purpose of discussing it tonight is to show the viewer, the consumer, the patient, that yes, this is part of the new technology, and perhaps there are different types out there, the bifocals.
And again, the purpose of this lens is to keep patients from having to wear bifocals afterwards. Because everybody, you know, the state of the art is that people put on their bifocals so they can read, and this would help them avoid having to wear bifocals. These mechanical lenses that shift literally back and forth are one idea, but I think the idea that seems to be going forward a bit more is the non-mechanical lens that has those little rings up on it that allows light to be focused both at distance and at near simultaneously.
Let's go to visual number 15, and this is the light adjustment lens. And this comes in touch with fine tuning with the laser. Why?
This shows a lens that's placed in the eye, and this is not available currently, but this is a future technology where that will be available soon. But a lens could be placed in the eye, and then a laser could be used to fine-tune it. And the schematic in the lower left basically shows what happens to that lens as laser energy is applied to it. And basically it allows the power of the lens to be very slightly altered specifically for that patient.
When do you expect this to be available? Is it being researched now?
Absolutely. I suspect that this type of thing will be commonly available within 5 years.
Yeah, it's currently being used, or being tried out, I should say, in Europe in 2005, and Dr. Stewart's correct, probably about 3 or 4 years before it's available here.
Maybe that's a future show for you guys.
There you go.
As we continue to address new technology. And then I think our very last visual we have to share before we take more calls is the laser procedure. And you have I think it shows the lens itself. Why are we looking at this?
This is an image of the implant with the pupil dilated. You can see the corners there, and you can see the circular yellow in the center. That's the implant itself. And behind there is what's called the capsule, which becomes cloudy over time. You can see that little white opacity there. And what we apply laser to is to that opacity to essentially clear that out from the center of the vision, allowing people to regain the vision that they once had after surgery.
Very good. Well, let's take some calls. We have some viewers who have been on hold for a while. We're going to go to Virginia and Charlotte first. Hi, Virginia. You with us? Virginia? If not, let's go to Mabel in Concord. Hi, Mabel. Welcome to HealthWise.
Right. And Dr. Bourgeois has been my doctor, and the last 2 times that we talked about it, he said they still weren't bad enough to do any surgery. Now, I know I need new glasses, and there's been a death about having the surgery, because when he did my husband's cataracts, eventually he had glaucoma come in his eye. Does anything about the cataract surgery cause glaucoma? Is that something you could get regardless, or have happen to you?
Good question, Mabel. Let's see what they have to say. Can the cataract surgery promote glaucoma?
No. In fact, what we frequently see is after cataract surgery, the pressure inside the eye can actually go down a few points. Glaucoma is something that happens as we mature, and folks who have cataract surgery tend to be a little bit more mature, and so a lot of these folks will go on to develop glaucoma regardless of the cataract surgery. Good question, though.
Yeah, it was good. Mabel, thank you so much for tuning in tonight. Let's go to Robert now in Charlotte. Hi, Robert.
Hello.
Your question tonight.
Yeah, I'm a patient of Dr. Stewart's, and the lens replacement is truly remarkable, truly fantastic. If there's somebody out there wondering and hesitating, get on with it and do it, by all means. It's really wonderful.
Did you hesitate for a while?
Yes. Yes, I will. A year now, at least, yes.
And it's like a new world for you, huh?
Incredible. Like a large print in good light, I don't need my glasses. And that was truly revelation.
Well, Robert, we thank you so much for calling in, and good news for you. So you've had no complications since the procedure.
No, it's truly incredible. They detained me in their office just hours. I was in and out in no time, and the following day was just a vague memory. It's really incredible.
Good news, and thank you so much for sharing that with us.
Okay.
Well, I guess that's what makes your job that's why you're doing this.
It's very fulfilling. I mean, for folks to be able to come in, unable to enjoy, watching their grandchildren grow up, can't see them very well and things like that, and to instantly be able to, the next day, to be able to see them without glasses frequently, it's a change in their lives.
It is, and the ability to do that with, and be minimally invasive about it, so that patients really, sometimes the next day when they come in, you almost have to look at the chart to see which eye you operated on, because the eyes don't look red. It's really neat, and it's all technology driven. These newer instruments that we have and the new lenses, these simply were not available 15 years ago.
Let's go to Graciela. She calls from Charlotte. Hi, welcome to HealthWise.
Hi. Thank you for taking my call. Can you hear me well?
Oh, we can.
Yes.
Your question.
I have had lenses implanted in both my eyes. My right eye was 6 years ago, and I already have had laser applied to open up for more light to come through. And then I'm not a diabetic. I grew up in bright, dusty places, and all the women in my family have this type of cataract, so I got them from them. I would like to know, is there any idea the life expectancy of these lenses since I was still in my 40s when I had my first one implanted, and what is coming down the pike, for people who have had both eyes done already?
Great questions. I am so glad you called those in. Who wants to take it?
These lenses should last a lifetime. You should never need them changed, and there really should not be any problems with them. You've had the laser procedure done already, so that should not be an issue. So you really should enjoy a trouble-free life with these lenses.
I have a follow-up for her. If there are different types of new lenses or procedures down the pike, like she asked, would she be a candidate for such, or once she's already had a procedure, that's it for her?
Good question. I would suggest that typically once these lenses go into the eye, that getting them back out and to replace them with a newer lens probably involves more risk than that patient wants to get into. So typically once a lens implant is placed, you would not want to remove it. For instance, the new bifocal implants. Patients will sometimes inquire about whether they could have their older lens implant removed to have a bifocal lens implant placed, and that's not something that we would typically advise.
But people who've had cataract surgery done before, there are options such that if they have a residual prescription, which happens about 50% of the time after cataract surgery, even with the current technology, you can do LASIK a couple years after surgery. You can consider, actually, some people are considering putting what we call piggyback, an additional implant inside to fine-tune the prescription. Those are, if the patient really twists our arm, we would consider those things. Usually, patients are happy with what they have, but you know, those who are motivated, there are options.
Graciela, I had to ask that follow-up for you. What, do you have one as well?
This is absolutely wonderful. I want you to know that my life has improved so much. I am a nurse, I'm active, I travel a lot and all that, and I just happened to develop premature cataracts. And I really would like for people out there, like the other gentleman said, I cannot explain you how much my life has improved, my enjoyment since I had the surgery done.
And let me ask you something. Before you had the procedure and when you realized you had this new world, did you realize what you were missing out on prior to surgery?
Well, I wore glasses for myopia since I was 10. And with me, it was a scary thing because one day I woke up and I felt like I had a cotton ball in my right eye, and I panicked. I thought, oh my gosh, I'm going blind.
Yeah.
And I grabbed the phone book, and the first doctor that would see me, I ran over there, driving very slowly. And he took a look at the different types of cataracts. The doctor said, this came out suddenly, and I said, yes. And he told me, and they run in your family, don't they? And I said, yeah. And then he said, well, there is you are a prime candidate for these. And I was aware of the procedure. I just never thought I was going to be a candidate that early because I was still in my 40s.
Yeah.
And 3 weeks after the surgery, I went to Ireland, and I didn't miss a single shade of green. It was such a wonderful thing. And he told me, the other eye is not so bad, but you're going to need it soon enough. And sure enough, 3 years later, I was ready. I mean, my eye was ready for that. And so I have monovision. My right eye is for driving, and my left eye is for reading. And before this, I never needed glasses for reading, and I'm an avid reader. And I am just so happy. 6 years later, I am as excited now as I was then when the next day after the surgery, I opened my eye and I could see 20/20 for the first time since I was a child.
Graciela, thank you so much for sharing that with us tonight.
Thank you for taking my call.
Yes, thank you.
Keep doing a good job.
Thank you.
One thing that this caller brings to mind is frequently we see, I'm sure Dr. Stewart as well, folks who say they just woke up and they lost vision in the eye.
I was going to ask you about that.
In fact, that happens actually over time. It's just that the brain does a great job if you have one eye that's becomes cloudy to use the other eye that's good. And so patients will walk around with just one functioning eye and not realize it.
Yeah.
And if a fly comes up or they need to close their good eye all of a sudden, they have to use their bad eye, they realize, wow, I can't see.
But for her to notice that quickly, waking up, does that mean that the cataract ripened?
Well, it could be, but another important fact is that if somebody does wake up and they notice that their vision is blurred in one eye, I would definitely not assume that it's a cataract.
Right.
Because it could be a cataract, but it may also be a retinal detachment or some macular problem. So the take-home message would be for that patient to get to their eye doctor as soon as possible to have a diagnosis given.
Right. Great advice. A couple more calls here we have. Dick in Waxhaw. Hi, Dick. Welcome to HealthWise.
Hello there.
Hi, your question tonight.
Yes, I'm calling for my wife. She had cataract surgery over a cornea transplant. due to keratoconus, and she has extreme light sensitivity. 2 pair of sunglasses outside don't really take care of it. Yeah, anything can be done for this?
Good question.
Couple of thoughts on that. There's a lot of causes of light sensitivity after surgery. One could be that the pupil is large, and there are various drops we can use to constrict the pupil, make it smaller, to let less light come in. There are actually, if it's really bad where the pupil doesn't come down at all and is actually quite large, there are pupil or iris transplants or implants you could put to make it small, not let as much light in. Alternatively, if this is short-term after cataract surgery, there could be some low-grade amounts of inflammation that causes sensitivity to light that might benefit with being addressed. And then finally, the one thing that can cause it is just when people have what's called blepharitis or inflammation of the eyelids secrete an irritating oil that becomes light sensitive, and that can cause sensitivity to light as well. So there's a whole host of different things that your ophthalmologist could evaluate you for and then be able to come up with a plan.
Dick, we really appreciate you calling, and good luck to your wife. Let's go up the road to Maxine in Taylorsville. Hi, Maxine.
Hi.
Your question.
I think they answered part of it a while ago.
Okay.
30 years ago, when I was 45, I had cataract surgery and had to wear a contact for some time because they were, I guess, wasn't into all this new stuff. And then they did an implant, the inocular lens, and I know that they're better now than they were when I got mine. And I was wanting to know, do they take out the old lens and put in something more modern? Or do you live the rest of your life with it? I am 75 now, so really, it really doesn't matter, but that was something I'd like to know.
Well, of course you would, and let's hear what they have to say.
Okay.
Well, I believe that she had cataract surgery, and I wasn't clear if she had an implant placed or not.
Initially,
Did not. So she may wear these very thick post-cataract glasses that many of us have seen years ago. We don't see these any longer because all patients today have implants placed in the eye, which avoids the use of these glasses. But when people put these glasses on, it makes the eyes look very big. So my advice to you would be to visit with your eye doctor to see about whether what's called a secondary implant can be placed in the eye. And that is something that is commonly done. We haven't shown examples of that this evening, but there are special implants that go in the eye that can help your problem.
Thank you so much for calling. So there are people out there who have had cataracts removed, but they never had a lens put in?
Yes, and they are either wearing these very thick cataract glasses or they're wearing a special high-power contact lens. And that is a workable situation for a lot of people, but some patients are interested in having these secondary implants put in, and that is something that can be done typically without any difficulty or without trouble, but sometimes it can stir up trouble. So I would visit with your eye doctor, and they can give you better advice about whether or not that would be a good idea for you.
We just have a couple of minutes left, and what I want to address in this time period is, and we've talked about this in the past when we do eye shows, you know, when you go in for an eye checkup, it's like having a mini checkup for the rest of your body, is it not? And why? Explain that.
Well, the eye is a window into the body. You hear that frequently, and there's a lot of conditions that we can pick up by doing a comprehensive eye exam. From the front of the eye, if you have little corneal or cholesterol deposits in the front of the eye, you can check for patients who have
vascular
high cholesterol.
Disease.
Vascular disease. If you look in the back of the eye, the blood vessels look abnormal for high blood pressure and diabetes and inflammations of the blood vessels and things like that. So you're right. There's a lot of things we can pick up where the patients don't even realize they have it with a comprehensive eye examination.
Dr. Stewart, put this in a nutshell for us.
Well, a comprehensive eye exam makes sense for everybody to do on a regular basis because the main thing you want to make sure that you don't have is some treatable eye disease. Yeah. And you want to catch treatable eye disease before it robs you of your vision. And things like glaucoma, early macular degeneration may not have any symptoms. And if those can be detected and treated early, it may spare patients their vision.
Wow. Dr. Kashyap Kansupada, we thank you so much for returning to this broadcast. I think it's been a fascinating show.
Thank you for having us again.
Oh, and thank you so much for your medical expertise. Dr. Donald Stewart, thank you.
You're welcome.
Thanks again.
Thank you, Joey.
And I'm Joey Popp. We thank you for tuning in as always. And as always, we hope that this medical broadcast has helped you become more health-wise. Make it a great week, and once again, enjoy HealthWise on WTVI for the season to come.
If you are interested in sponsoring a show, being a guest on HealthWise, or have questions or comments, please contact us at 704-371-8836, on the web at healthwise@WTVI.org, or by mail at HealthWise, care of WTVI, 3242 Commonwealth Avenue, Charlotte, North Carolina, 28205. If you would like support group information about tonight's topic or any HealthWise topic, call SupportWorks at 704-331-9500. For more information about tonight's guests and future HealthWise shows, call the HealthWise info line at 704-371-8836. Learn more about HealthWise and other local productions at WTVI.org. Go to our website and you'll see current and upcoming events on air and in the community. That and much more at WTVI.org. Stay tuned for This Old House, coming up next on WTVI. An educational grant for HealthWise is provided by Alcon Surgical.